of a career. I was at Duke Medical Center. I just a couple months ago moved across the street to Veterans Affairs Hospital. And I have been asked to speak on evaluating the mediastinum on the chest radiograph. To begin, just to be sure that we're all on the same page, I'm going to define the mediastinal compartments and what structures lie in each within each compartment. And once you know what structures are in each compartment, then you can come up with differential diagnoses for the various different pathologies that can affect those structures. I'm going to be spending the majority of my time focused on showing you cases regarding abnormalities in mediastinal lines and interfaces. Because recognizing what is normal in terms of mediastinal lines and interfaces is key to being able to then perceive an abnormality. I realize in this day and age, we're not going to rely on the radiograph to characterize a mediastinal lesion, but we do rely on the radiograph to give us the first hint that there is an abnormality in the mediastinum that then needs cross-sectional imaging to help characterize it. And some of those mediastinal lines and interfaces, an abnormality of those is quite obvious, and you'd easily pick up that there's an abnormality, but sometimes the abnormalities can be quite subtle. So my goal for you at the end of this lecture is to be able to recognize abnormalities of the mediastinum and mediastinal interfaces to be able to perceive that there is a potential lesion that needs to be worked up. I'm going to be doing this primarily as a case-based approach, and I'll pause at various different times at the end of each case to let you ask questions in the chat. All right, so there are a variety of classification systems for mediastinum. Most of them are based on the lateral radiograph and various different landmarks that can be seen on the radiograph. Some people start off by dividing the mediastinum into superior and inferior mediastinum. And that border between superior and inferior is based on sort of a hypothetical line between the sternocleidomanubrial joint, then going backwards to the inferior end plate of T4. It's a very hypothetical line. I personally don't find that distinction to be that helpful. So I'm going to be talking about the anterior, the middle, the posterior mediastinum, and how we recognize those structures on the radiograph. The anterior mediastinum in the classification system that I use, and I think probably most people use, is the area immediately posterior to the sternum, and it is in the prevascular space. So it is anterior to the heart and the great vessels. So the posterior border of the anterior mediastinum is going to be the heart, the right ventricular outflow tract into the right, into the main pulmonary artery, and the ascending aorta. Those are going to be where the anterior mediastinum ends. Anterior mediastinum in an adult contains a lot of fat and some small, few little vessels, internal mammary vessels, for example. But from a pathology standpoint, it contains thymic and germ cell remnants that can then grow and develop lesions that we can then see on the radiograph. A lot of people include the thyroid in the anterior mediastinum. the thyroid, as you know, is in the neck, in the paratracheal region. And as it grows, sometimes it can extend into the thorax, into the retrosternal anterior mediastinum. So I put that in parentheses because you generally don't see anterior mediastinal thyroid lesions unless it's very clear that there's thyroid pathology more superiorly and involving the paratracheal middle mediastinum, which we'll get to in a second. So because anterior mediastinal lesions, because the anterior mediastinum contains thymic and germ cell remnants, you can have a host of lesions involving the thymus or germ cells. So you can have thymic hyperplasia, thymic cyst, thymoma, thymic carcinoid. The list goes on. There's a huge number of thymic lesions. Same with germ cell. I listed two here, teratoma, seminoma. There's yolk sac lesions. There's embryonal cell. So there are a host of germ cell tumors that can stem from these remnants. And then again, if there is evidence in the paratracheal region of something coming down from the neck, then you can include thyroid pathology as well. I think just a little sort of shout out. I think a lot of people think of the T's differential for anterior mediastinal lesion differential. And in that T, it's sort of a mnemonic. People talk about thymoma and teratoma and thyroid. Just a little shout out that there is, in fact, a whole host of thymic lesions, a whole host of germ cell lesions. So if you may think thymoma just to remember a T, but remember to actually broaden that differential when you're talking about the thymus, and same with germ cell tumors. Okay, the middle mediastinum, that's a lot of the vascular structures. So that's what I have here by the brackets. So the heart, the main pulmonary artery, the central pulmonary, right and left pulmonary arteries, the ascending aorta, the aortic arch, the SVC is in there. A lot of the major cardiovascular structures are considered to be part of the middle mediastinum, as are the airways, the trachea, the central bronchi, mainstem bronchi. And again, the thyroid I include in the middle mediastinum because it's paratracheal, and it as it enlarges and becomes pathologic, it can extend down into the past the thoracic inlet into the middle mediastinum. So middle mediastinal lesions, things that involve the heart, things that involve the aorta and major vascular structures, things that involve the airways. So a lot of the airway tumors. And then again, things that involve the thyroid. So knowing what's in the mediastinum, you can sort of tease out what potentially could be in a differential. And it's all based on the anatomy. Posterior mediastinum, the classification that I use, is the area within a centimeter of the vertebral body. So it extends anterior to the vertebral bodies, and is, the anterior border are those vascular structures that I talked about before. And it includes the spine and all the nerves that come out of the spine, out of the spinal canal, the esophagus, and the descending thoracic aorta. So, we can then figure out what to include as potential pathologies based on lesions that can occur to the vertebral body, the bones of the spine, the nerves that come out of the spinal canal, the esophagus, and the descending thoracic aorta. And then I always remember that in any mediastinal compartment, there's fat, there are lymph nodes, there are vessels, and there are some mesenchyma, so that you can get lesions involving fat, mostly too much fat, lipomatosis. Lymph nodes, either reactive, metastatic disease, lymphoma. Any pathology involving a vessel and a mesenchymal tumor like a fibroma or sarcoma can occur in any mediastinal compartment. Okay, so that's just sort of setting the stage, anterior, middle, posterior, what entities lie in each and where where they're delineated. Okay, we're going to start off with the case. This is a young person with a history of chest pain. There is I think, a pretty obvious abnormality. And so my question is, what's the mediastinal, what mediastinal compartment does this abnormality lie in? And then, therefore, what sort of pathologies are we thinking about? Now, I want to just take one little step back. And, I said I thought it was relatively obvious that there was a mediastinal mass, but I realize I should clarify that to make sure that we all understand each other. How do I know that this homogeneous opacity that is lying midline on the chest radiograph is a mediastinal pathology? It's a mediastinal lesion. How do I know that it's not something, for example, sitting on top of their chest wall, on the middle, on their mid chest wall? Well, we use the silhouette sign. That is, in using the silhouette sign, it places this mass within the thorax and within the mediastinum. So I see on this radiograph bilaterally well-defined margins along the lateral aspect of this opacity. So very sharply demarcated, what I refer to as pushing margins, suggesting that there is something that is extra parenchymal, not in the lung parenchyma, but pushing against the right and left lung. But what I don't see is the superior border or the inferior border. And I don't know whether, and so I don't see exactly where this thing ends superiorly, and I don't see exactly where it ends inferiorly because I can't see those superior and inferior borders. So the fact that the superior and inferior border is silhouetted out, that I don't see it, tells me that it is immediately abutting the structures that lie adjacent to it. So this is midline, it's abutting the mediastinum and silhouetting out the superior and inferior margins. Now so that's why I think there's a mediastinal mass here. Then the question is, what portion of the mediastinum is this mass located? Well, again, we use the silhouette sign. And what do we see? What is not being silhouetted out? Well, the descending thoracic aorta is very well demarcated here. And I just said a few minutes ago that the descending thoracic aorta lies in the posterior mediastinum. So this mass, which we see the lateral margins extending to the level of the descending thoracic aorta. The fact that the descending thoracic aortic border is not silhouetted out means that that mass is not immediately abutting it and is likely not in the posterior mediastinum. I also see the transverse aorta quite well, which I said I usually include in the middle mediastinum. Furthermore, on the right, I see the vertically oriented SVC, and I see the nice thin paratracheal stripe, and the trachea is not deviated. So the SVC I include in the middle mediastinum. Trachea I include in the middle mediastinum. The fact that those structures are not silhouetted out, as well as the fact that the transverse aorta is not silhouetted out, I don't think this is in the middle mediastinum, which leaves the anterior mediastinum. And getting a chest lateral radiograph confirms that we have abnormal soft tissue in the retrosternal anterior mediastinum. Certainly go on then to CT, which shows a homogeneous soft tissue mass, and have differential, including thymic pathologies, germ cell pathologies. This does not extend down from the neck. There's no paratracheal deviation, so this is not going to be thyroid. And then remember to include lymph nodes, particularly in the anterior mediastinum. You want to think about Hodgkin lymphoma. This is not a vascular pseudoaneurysm, so we can cross out a few things. In a 25-year-old, there are thymic lesions, germ cell tumors, and Hodgkin's that we think about primarily, and you stick a needle in it. This person got a percutaneous biopsy, and this was Hodgkin's lymphoma. Okay, I'll stop there for a second. Was there any questions about that? Anything I've covered thus far?
There's a question that was asked before you started the first case.
Okay.
So the question is how to differentiate a positive cervicothoracic sign due to thyroid extension versus opacities formed by the SVC shadow.
Okay, well, I will tell you that primarily, but the thyroid, anytime the thyroid enlarges, it virtually always deviates the trachea, which the SVC will not do. So that, just to sort of answer your question, that's how I would answer your question, is by looking at tracheal deviation. I'll also just say that we will be talking about the cervicothoracic sign in a bit. So we'll have more about that in a minute.
Awesome.
Okay, so here is a 40-year-old with a history of melanoma. This film comes across, and question is, what mediastinal line or interface is abnormal? I'm telling you that there is an abnormality. And based on that mediastinal line and interface abnormality, which compartment is involved? So I don't think this is, I think this is a relatively subtle case. I don't think that this is like so obvious as was the case before. The abnormality here is in the what's referred to as the AP reflection or the AP line. Those two things are synonymous. And essentially, this is referred to as lateralization of the AP line. We have a very straight line of an opacity that projects lateral to the transverse aorta. And that is abnormal. That is not what we should normally see. So, oops, I seem to be frozen. Here we go. So normally, the AP reflection or the AP line, if we see it at all, it will project medial to the transverse aorta. So here is this very straight line of a opacity that is medial to the transverse aorta, and this is a totally normal AP reflection or AP line. The AP line represents the junction, or the interface between the left lung and the anterior mediastinum. And based on this cross-sectional image, you can imagine that in a frontal radiograph in which the X-ray beam is going either AP or PA, that interface between the lung and the anterior mediastinum should project medial to the most distal aspect of the arch. So when you have lateralization of the AP line, where that line is projecting lateral to the transverse aorta, that is indicative of something in the anterior mediastinum that is causing that interface to be deviated laterally. Usually that is fat. In a huge percentage of people, that is fat. You get, exuberant fatty deposition within the anterior mediastinum, and that interface between the lung and the anterior mediastinum projects lateral to the transverse aorta. And I mean, I will tell you that sometimes it's obvious that it's going to be fat based on, first of all, the patient's body habitus, the chronicity of the abnormality, if it's been there, on multiple films for years. Often if the patient is on steroids and they have extra fatty deposition, there are that, again, the vast majority of the time, this is due to fatty deposition. Problem becomes when you have, for example, a history of melanoma, as in this patient. I don't want to just assume that this is fatty deposition. I know that there's something now going on in the anterior mediastinum, and I want to be sure, frankly, that there's not a mediastinal metastasis to an anterior mediastinal lymph node. So again, there are a host of things that could be in the anterior mediastinum. In somebody with melanoma, I worry primarily about metastasis. This person, when they got a CT, had a very homogeneous anterior mediastinal mass that measured fluid density, had absolutely no soft tissue component, no portion that was enhancing. So this was a thymic cyst that can be congenital, but can be acquired as a result of chemotherapy, or some people post-radiation therapy, particularly for lymphoma. So, but that anterior mediastinal abnormality is delineated by the fact that there is lateralization of the AP line. I'm going to do one other case and then I'll stop for questions. So here's another person with a history of melanoma. And the question is, what mediastinal line and interface is abnormal here? And what compartment, mediastinal compartment, does that place the abnormality? So here, we actually have a normal AP line. So there is a straight line medial to the transverse aorta. So the AP line, the anterior mediastinum, check. But there is a convexity between the aorta and the region of the main pulmonary artery. There is a small little soft tissue convexity in this left mediastinum, just under the transverse aorta. This is the aortopulmonary window, the AP window, and the presence of that convexity is abnormal. There should not be any convexity in the AP window between the aorta and the main PA. So again, the AP window is the space under the bottom of the aorta and the top of the main PA, and it is considered part of the middle mediastinum. And on the frontal radiograph, there should not be any convexity in the AP window. We see on this magnified view, we see the transverse aorta and the descending thoracic aorta, but the region under the transverse aorta, just cephalad to the region of the main PA, that is concave to the left. There's no convexity. That is a normal AP window. Our patient, that is not the case. So just under the transverse aorta, we had this little convexity, which tells me that there is something in the middle mediastinum. Giving further evidence that there is something in the middle mediastinum is the fact that if you look closely, it looks like there is narrowing of the proximal left mainstem bronchus and the distal thoracic aorta at about the level of this abnormality. So that suggests that there's something in the middle mediastinum adjacent to the airways. And I think this is scary. It's all scary can be, because there is a huge middle mediastinal mass, which results in a pretty subtle abnormality on the radiograph. And it is this convexity in the AP window that clued us in. We see some narrowing of the left mainstem bronchus here in this very heterogeneous, partially necrotic mediastinal mass. Again, we sort of go through, think about the different entities that this could be. In someone with a lesion that looks like this, that with a history of melanoma, this is most concerning for a melanoma metastasis, which was indeed confirmed on transbronchial biopsy. Okay, so I'm going to stop there. AP window, AP line. Questions about that?
Those was definitely mind-boggling cases.
I know.
I'm I'm just still processing it. Okay. So we have a few questions here. I'm
Yeah.
gonna start off with the first one by Christoph is asking what is meant by a positive silhouette sign?
A positive what sign? I'm
Silhouette.
gonna probably not know the answer to this question.
No, a silhouette. I
Oh, a
pardon.
positive silhouette sign. I'm sorry. I thought you said something totally different. Oh, a silhouette sign is means that two structures that have similar densities, so soft tissue density, calcium density, for example, if they're similar densities and they immediately abut one another, they touch one another, you will not be able to see the border of where those two structures touch. So the borders of the structures will be, we call, say, silhouetted out, obscured when they touch one another. So the fact that, for example, the transverse aorta and the well, here I'll do it on the other side. So this very, very thin stripe that we see that forms the border of the trachea, the fact that we see that stripe separate from the line of the SVC means that the SVC and the trachea in this person don't touch one another. They're separated by something of a different density. So, and that's they're separated. So there's usually fat there. I mean, where would we talk about silhouetting out? Here, the fact that the transverse aorta is seen through this mass as a separate entity means that the transverse aorta and this that other opacity are not of the same density and immediately abutting one another. That's what the silhouette sign is. We use it all the time in chest imaging. So yeah.
Okay. Next question. What is the criteria for mediastinal widening?
Um, that depends on whether it's a PA film, an AP film, whether it's done supine or erect. I look more at I don't have a number. I mean, I'm sure there is a number. I guarantee there's a number out there for a PA film and how wide it's allowed to be. I don't remember what that number is. I look more at the contours, the interfaces, and rely more on that than I do any given number. If somebody knows a number, please tell me. I'm sure there is one. If you look it up, I'm sure it's on Radiopedia or something. You
Yeah,
can teach me.
I mean, and as a peds rad, I think like even with age, how would you tell, right? I mean, what is
Right.
what is
Yeah. Well, yes, with peds rats, so the thymus and then it involutes and yeah. Yes. Right.
Yeah. All right.
Sorry.
That's fine. The next question is a little bit confusing for me, but I'm just going to read it out as is.
Okay.
Does the normal AP line usually mean anterior mediastinum is normal? Can there be a normal AP line and increased paratracheal stripe? That means a superior mediastinal mass.
Sure. And the AP line, yes, the AP line is just um the the interface of the lung with the right lung, sorry, the left lung and the anterior mediastinum. That is one the audience member is correct. If you go above the level of the sternal notch, you can have an abnormality in the what I would refer to as the the superior middle mediastinum, and still have a normal AP line. You can also have an abnormality of the anterior mediastinum that's on the right and have the left AP line be totally fine. So yeah, there's no 100% here. This is just with I'm trying to give you ways to pick up subtle abnormalities that but the absence of these findings does not preclude a mass somewhere else.
Got it. Yeah. The next question is by an anonymous attendee who is asking, please can you explain how to differentiate a lung mass versus a mediastinal mass? I also have a similar question from another attendee that who is asking that the mediastinal mass has an obtuse angle with the lung parenchyma, but how do you measure it on the radiograph?
Um, so as in with that first case, so I determine that something is mediastinal as opposed to within the lung if it's borders with, if it seems to be, let me try just make sure I'm going to say this clearly. If its borders with the mediastinum are obscured so that it is abutting the mediastinum and has a well-defined border against the lung. That to me tells me that this is a mediastinal mass that is pushing out against the mediastinal pleura in the lung, as opposed to a lung mass that is invading the mediastinum. If it was a lung mass that was invading the mediastinum, then the borders with the lung would not be very sharply demarcated, as if it's extra parenchymal pushing against the mass, pushing against the lung. Rather, the borders with the lung would be ill-defined because it would be involving the lung. And so yeah, and you can't be 100% right all the time. I'm sure somebody can find me a case of a mediastinal mass, of a lung mass that happens to just abut the mediastinum in such a way that it could be a mimic. But these are sort of overall overarching rules.
Got it.
So, and again, the idea here is to pick up an abnormality on the radiograph to then further evaluate on cross-sectional imaging, CT. So the goal here is not necessarily get the diagnosis as much as to pick up that there's an abnormality that needs further evaluation.
Got it. So the next question is, what does the acronym AP stand for? And is there an AP line on the right side as well?
Oh, sorry. AP stands for aortopulmonary. I'm sorry, I should have said that. So it's the aortopulmonary line, the aortopulmonary window. That's what the acronym stands for. And there is not an AP line on the right, as far as I know.
Right.
I'm going to move on
Sure.
because I want to get through some more cases. Oops. And we can hopefully do some more at the end, in a bit, more questions. Okay, this is a person who comes in, has fever and back pain. There is an abnormality. My question to you is, what is a radiologic sign that we are seeing, and where is the abnormality located? So what I see what first strikes me as bilateral hilar enlargement and contour abnormalities. So at first glance, one could wonder if this is an example of bilateral hilar masses, bilateral hilar adenopathy, something like that. But notice that through these abnormal contours, we see the individual hilar vessels. I can see where the right descending interlobar, the right hilar artery is. I can see the left hilar artery within the contour abnormality. So again, this is an example of the lack of a silhouette sign. So we can see the pulmonary arteries through these opacities. And that tells me that these opacities do not abut the hilum. They are either lesions anterior or posterior to the hilum. So then we get our lateral radiograph. And the hilar structures are here in the middle of the lateral. Anterior to them, everything looks normal. I don't see any increased density. But posterior to the hilar structures, we see an abnormal opacity that is immediately adjacent to an acute kyphosis within the thoracic spine, potentially related to this person's back pain. So the fact that there's an abnormal opacity just anterior to the vertebral column tells me that these opacities that I'm seeing on the frontal film likely are in the posterior mediastinum. So we have the posterior mediastinal differential. We're probably, in this case, given the acute kyphosis, given the back pain, I'm guessing that this is something related to the vertebral bodies. And one could wonder whether this is an acute fracture, severe compression deformity with, for example, paravertebral hematoma within the posterior mediastinum. Patient is fever, though. Could this be something related to osteomyelitis? Looking at a magnified view of this spine, you notice that there are actually two sets of posterior elements for what seems to be a single compression. So the fact there are two different posterior elements tells me that there are actually two vertebral bodies involved here that are adjacent to one another and look like they are being destroyed, bottom of one vertebral body and the top of the next. So this is likely not just a fracture with hematoma. On the cross-section on the axial view, we can see how all this paraspinal soft tissue could project superimposed over the hyla on the, if we were looking at a frontal radiograph. Same thing here. We see all this paravertebral soft tissue with destruction of two adjacent vertebral bodies. So this is kind of a classic finding with destruction of two adjacent vertebral bodies of vertebral osteomyelitis, and this is all paraspinal phlegmon and paraspinal abscess in someone who turned out to be bacteremic. So hilar overlay sign tells us that the abnormality that we are seeing is not in the hyla, but rather is either anterior or posterior. And again, is all about the silhouette sign. I'm going to do one more case and then, well, maybe I'll do two more and then stop for questions. Here is somebody who has cirrhosis. They have a pre-transplant chest radiograph. They're going to be getting a liver transplant. My question to you is, what mediastinal line or interface is abnormal? And what compartment, therefore, does that place the abnormality? Again, I think relatively subtle. Our eye is automatically drawn to the mediastinum because I'm asking you about that. And I will tell you that one of the first things that I see is that there is a abnormal right paraspinal line. So there is a focal convexity to the right of the spine. Normally, we don't see anything to the right. Oh, here's a magnified view. Normally, we do not see anything to the right of a spine on a normal chest radiograph. There is spine and that's it, but sometimes we'll see something to the right of the spine because it's fat. Sometimes we'll see something to the right of the spine because the osteophyte is growing to the right. But on a totally normal film, we shouldn't see anything to the right of the spine. We do see things to the left of the spine because of the descending thoracic aorta, which usually descends to the left, on the left. And as a result, we can see on a frontal radiograph the descending thoracic aorta that projects to the left of the spine. But here we see this focal convexity to the right of the spine, which is abnormal. And suggests to me that there's something going on in the posterior mediastinum. It could be something as trivial as an osteophyte that I don't appreciate on the radiograph, or a hiatal hernia coming up from the stomach, or focal fat. But why it would be focally depositing fat right there, that'd be a little unusual. And then I also noticed that there's an abnormality on the left as well. So the descending thoracic aorta is coming down, and then all of a sudden there is a focal convexity to the left. Again, could be an osteophyte, could be something trivial like that. But in someone who's about to get transplanted, a liver transplant, I want to make sure, my first thing that I want to make sure is that this isn't metastatic disease from a occult hepatocellular carcinoma. So that's what, like, I want to be sure before the person gets a new liver. So, there are a variety of things in the posterior mediastinum that this could be. This, not a big, huge surprise, turned out to be paraesophageal varices in someone who had portal hypertension from their cirrhosis. But picked up that there's an abnormality first because I'm seeing something to the right of the spine on a frontal film. This portion of the posterior mediastinum would be projecting to the right of the spine, which is not usually seen. And then I'll do this case and then pause. So here's a patient. They have a homogeneous opacity with a broad abutment against the mediastinum and a pushing margin, very well-defined margin against the lung. So that suggests to me that they have a mediastinal mass. Question is, where do we think this mass is located? And how do we figure that out? What sign are we using to figure that out? And hint, somebody's asked about this already. So in this mediastinal mass, through it, we see the transverse aorta. So that means the transverse aorta is not immediately abutting this mass. Transverse aorta is middle mediastinum. So I'm guessing that this is not a soft tissue mass in the middle mediastinum adjacent to the aorta. I also noticed that this mass extends above the level of the clavicles. And not only does it extend above the level of the clavicles, it has a very well-defined border above the clavicle. So this is extending into the superior mediastinum. I said that most people delineate the superior mediastinum at essentially the T4 level. So this is going, pretty high up. And we're seeing a very well-defined border above the clavicle. That tells me, the fact that it's a well-defined border above the clavicle tells me that this mass is going to be in the posterior mediastinum. So here on the lateral view, the anterior mediastinum ends at essentially the level of the sternoclavicular joint at the angle of Louis, sternomanubrial junction, which is essentially at the level of the clavicles. So anterior mediastinum is not going to extend above the clavicles. Posterior mediastinum, because the chest is curved and essentially obliquely oriented, the posterior aspect of the chest is much higher than the anterior portion of the chest. So the posterior mediastinum can go quite high above the level of the clavicles, and there will be lung at that level, so it will be outlining the posterior mediastinal mass. And that gives a very well-defined border. When it's outlined by air, you get this very sharply delineated border that tells me that it's in the posterior mediastinum. So the fact that it goes above the clavicles tells me it's not anterior. And the fact that the border is very well defined tells me that it is posterior. The middle mediastinum, which has all the vascular structures, the trachea, the thyroid, That generally is not outlined by air. So the border of a middle mediastinal structure that extends above the clavicle is not outlined by the lung, so it doesn't have very well-defined borders. So I'll show you what I mean in a minute. So this being a posterior mediastinal mass, confirm that on the lateral view. That's, I thought I said this somewhere. I should have. If I didn't, I thought I did. This is referred to as the cervicothoracic sign that somebody asked about. So the cervicothoracic sign helps localize things to the posterior or middle mediastinum. When it is sharply well delineated above the level of the clavicles, that is places it in the posterior mediastinum. If it is poorly delineated with very ill-defined margins above the clavicle, it's more likely to be in the middle mediastinum. So this person got both first a CT and then an MR that showed a soft tissue mass. It was certainly not a vascular tumor. It seemed to be very separate from the esophagus. And it has a small little connection to one of the neural foramen. So this was favored to be of neurogenic origin and was a schwannoma upon resection. So here's a different patient in which there is abnormal soft tissue, abnormal density extending above the level of the clavicles. It's deviating the trachea, but the lateral portions are very ill-defined. So the lateral border is very hard to exactly say where it is. So the fact that this is not well-defined lateral border extending above the clavicles, this tells me that it's not a posterior mediastinal lesion. It's likely it's middle mediastinum because the anterior mediastinum doesn't go that high. And because there's tracheal deviation, first thing I would think of is a thyroid lesion involving the left thyroid. Conceivably, there could be some pathology, a giant aneurysm, pseudoaneurysm of one of the arch vessels. And this was indeed thyroid. And you can see here on this coronal reformat that the thyroid lesion is not going to be outlined well by the lung. There's still a lot of, there's vessels, there are other things. There's going to be some fat between the thyroid and the middle mediastinum and the lung, and that's why this border is ill-defined. And that helps me localize this to the middle mediastinum. So here it is, cervicothoracic sign. I think a positive cervicothoracic sign is actually where it is ill-defined above the level of the clavicles with a poorly defined lateral border, putting it in the paratracheal middle mediastinum, or, you know, if you want to just call it the paratracheal superior mediastinum, that's fine too. If it has a well-defined border above the level of the clavicles, then it places it in the posterior superior mediastinum. Okay, I have one more case and 5 more minutes. Let me do this and then I'll stop for questions. So here's a patient who is a known chronic right pleural effusion. That's been there for years. So we're going to put that aside for the time being. There is a mediastinal abnormality here. So what mediastinal line or an interface is abnormal, and what compartment does that place it in? So here's a magnified view. And what we see is an convexity of the azygoesophageal recess in the region of the subcarina. So here we see this contour in the subcarinal region that is convex to the right. So that is abnormal. So normally the azygoesophageal recess comes up. This is the interface of the right lung with the posterior mediastinum, comes up, and as the azygos vein is going to come over as the azygos arch and dump into the SVC, the azygoesophageal recess in the subcarinal region should be concave to the right. There should not be a convexity there. There should not be a bump in that region. It's specifically in the region of the subcarina. So anatomically, the azygoesophageal recess, here's the azygos vein, here's the esophagus. It is this interface between the right lung and that portion of the posterior mediastinum. And in the subcarinal region, this should always be concave to the right. And because it's in the subcarinal region, you can have a convexity as a result of a middle mediastinal lesion in the affecting the airways, affecting the carina, or you can have an abnormality of the posterior mediastinum causing a convexity. So a convexity of the azygoesophageal recess in the subcarinal region tells me that there's either a middle or a posterior mediastinal lesion. So in this person who has a convexity in the region of the subcarina, had a very large mass kind of enveloping the esophagus. It's in there somewhere, affecting the both the right and left mainstem. And on transbronchial biopsy was small cell carcinoma with an occult primary. Didn't ever find the primary within the lungs. Okay, so with that, I'm gonna stop and see what questions there are.
I think we have just two questions.
Okay.
One is, can you please explain how to look for a widened paratracheal stripe?
Well, I don't think of it so much as a widened paratracheal stripe as an obscured paratracheal stripe. So the paratracheal stripe is the border of the trachea. It's the right border of the trachea, usually. We talk about it on the right much more often. And usually in the paratracheal middle mediastinum, there's fat. So the fat density is not the same as the density of the wall of the trachea, and so you can see this thin stripe. If you have, and I guess you can see it right here. If you have a soft tissue mass that's the same density as the wall of the trachea, immediately abutting the trachea, then there is obscuration of the paratracheal line. And so then it's silhouetted out, you don't see it. And I think of that as being more common than actual widening of the line. I think the line, the border should be 3 millimeters or less. I don't think I've ever actually measured it. If it's 6 millimeters, like I don't generally measure it, but I do, particularly on serial films. If it was present, if you could clearly see it on a prior study, and all of a sudden it becomes obscured, so you can no longer see it at all, that's a sign, usually of a lymph node, in the paratracheal region.
The other question is that sometimes there are focal humps in the dome of the diaphragm. What do we usually report it as?
I don't even mention most of them. If it's a very prominent hump, then I will measure, and I just have a frontal film, so I can't tell if it's anterior or posterior. I will say elevation of a portion of the hemidiaphragm. If I have a lateral and it is clearly involving the anterior portion of the lung of the diaphragm, I call that an eventration. Those are usually, that's a region of wall muscular thinning, and it's much more common in the anterior diaphragm. All right, so I just wanted to just remind you to always, in your differentials, always include lymph nodes and vessels, because we always tend to think in compartments as to what structures are specific to that compartment. But vessels and lymph nodes can be in any compartment. And in this person who had rim calcification around this mass, they were a little surprised to get pulsatile red blood. So just a reminder to always include that. All right. Sorry for going a minute or so over, and I want to respect your time. I'm here. If you have any more questions, you can certainly email me. So
Thank you so much.